Hello, everybody. This is Lisa Johnson. Thank you for joining us today. I'm here with our speaker, Jack Burke, and we will be discussing planning for continuity of operations in rural hospitals. I am Lisa Johnson. I am with Everbridge's healthcare team, and I'll be covering our agenda for today. We'll be looking at the disaster lifecycle and healthcare services, rural hospital characteristics and challenges, influencing forces, institutional risks, external expectations, industry expectations, and continuity planning. I'd like to introduce our speaker today, Jack Burke. Jack has spent 44 years in healthcare management and is retired from Harvard Pilgrim Healthcare as its Vice President of Corporate Compliance Programs. He has done many things across his long career in healthcare, but at the moment he's been very involved with Nantucket Cottage Hospital. He's been part of their governance structure since 2001 and has been a trustee since 2012. He is currently a vice chair of the board. Welcome, Jack.
Thank you, and good morning, good afternoon. This, as you just heard, is my first webinar. I have every intention of it not being my last, but I'm looking forward to it. By way of brief introduction for many of you in the audience who I suspect are emergency planners already, the disaster lifecycle is something that should be recognizable to you as the foundation for ongoing efforts, in as much as it is a process, it is not an event. It has its 4 phases, which you are, I'm sure, familiar with, each with its various components. I like to start in mitigation, in particular the hazard and vulnerability assessment component, because that leads to preparedness, to develop plans, to institute training. That readies you for a response, to stabilize the situation and assure life safety. That is followed by recovery. Clearly, any point on this circle can be the beginning of an event, but the circle is always in the background, and each step in it is something that needs to be considered. For healthcare services in general, there are 3 priorities which I'm sure you'll recognize as the core of why we do what we do. The first is to safeguard people in a hospital, whether patients, staff, family members, visitors. The second is to maintain the tempo of the institution and the continuity it needs to bring to the community that it is serving. And the last is to protect physical resources of the institution from harm, from further harm. That picture in the lower right is the front entrance to Nantucket Cottage Hospital, which is the only hospital on an island 30 miles at sea off of Cape Cod or southeastern Massachusetts. It is licensed for 19 beds. The facility is currently 60 years old. Significant because I'll get into aging physical plant in some of my slides later on. We are in the midst of constructing a replacement facility as we speak. The hospital serves approximately 15,000 people year-round, and like most resort communities, there's a surge during the summer months, which takes our effective patient population up to about 50,000. And with it, all the challenges that kind of exponential growth brings. Also, nothing I need to mention to any of you are the 6 types of preparedness plannings, which fall into 2 clusters. There's the natural group. The most prominent component there is the meteorological events. By area of the country, they're mostly geographically predictable, and in some cases they're seasonally expected based on peak seasons for things like hurricanes. The other major group is the man-made group, whether accidental or intentional through terrorism. We are concerned with events which have their origins in biology and chemistry, in nuclear components and power outages. And you have to consider all of these when you do a hazard vulnerability assessment, which I'll get into a little further on. But that's the full array that I'm sure you're already familiar with. So let's talk about rural hospitals for a minute. There are about 2,500 in the country at the present time. Actually, these data are fairly current, but as I'll note in a minute, they're on the decline. Whether they are up and running or up and limping along, they represent a crucial safety net not without weaknesses, for the catchment areas that they serve. They're often the foundation for an entire county's or region's clinical activities, whether they're inpatient or outpatient, whether they support a physician group, whether they house other health-related activities besides acute or community-level hospital care. They provide essential care for almost 1 in 6 Americans, 57 million people. It's about 17% of our population. As you would guess, or as you know if you practice in one, they're typically small facilities. They're in remote parts of their counties or their states where there is very low population density. The acuity of their patients is usually greater. Patients are older. They have fewer economic means than those in urban or community hospitals, and they're more likely to suffer from chronic illnesses, often situations that have been not been treated well in the past or not been treated at all. Rural hospitals have a higher mix of outpatient and home care services, which, while necessary, often are accompanied by lower Medicare payments, Medicare being the primary payer for a rural hospital. And in general, the hospital has modest assets with a greater dependence on public program reimbursement. The payer mix of care in a hospital usually has less commercial payers in play than they would in a community hospital or an urban hospital. Of those 2,500 or so, about half, more or less, are classified as critical access hospitals, significant because this was a new designation, now about 20 years old, that Health and Human Services, or the Centers for Medicare and Medicaid Services, created. And the distinct difference is that it's a cost-based reimbursement of about 101% of eligible costs. That was intended to reduce the financial vulnerability of these institutions throughout the country, and in doing so, maintain and hopefully even improve access to health care by residents in those counties. The typical critical access hospital has about 140 or so employees. That's large for the community that you usually find a critical access hospital in. And it maintains a payroll of about $7 million. So it's a major player in its community, and adds to the economic growth and the economic vitality of that community as well. However, they're difficult to maintain in as few words as possible. About 48 institutions and 1,500 beds came offline since 2010, the first half of the current decade. The ones you see in red closed. The few 7 or so that you see in green initially closed and have subsequently reopened. The span of reopening can be anywhere from a week to a physical problem up to 2 years, which is more often the case through a reorganization, re-ownership, or changes in the scope of service that is offered. The trend is not good. In 2010, there were 3 closures. In 2014, only a couple of years ago, there were 15. So it is not an evenly distributed rate of closure, clearly more trending toward difficulty. I'll say more about that in a moment. The root cause for many is states' failure to expand Medicaid enrollment, bringing additional volume and revenue to the institution. Excuse me, and as you'll note, a lot of red in the South, where the poverty in rural counties is most pronounced. Rural hospitals, I hope you can make the distinctions here with color, appear here in yellow, in green, with traditional hospitals in urban areas in yellow. As you can quickly see, each state, each state has both types, whether it's Wyoming's 6 people per square mile density. It has an urban hospital, I suspect, in its capital, but many rural hospitals surrounding it, as well New Jersey, with the most densely populated state in the continental U.S., and the entire U.S. for that matter, where there are a couple of rural hospitals not easily seen in that swath of orange that is the Northeast Corridor. But if you look around the country, whether on the West Coast, starting with Seattle, down to San Francisco, Southern California, coming across the country, Dallas, Chicago, Minneapolis, the East Coast of Florida, Atlanta, and that entire Northeast Corridor from Washington through and beyond Boston, you see the propensity of urban hospitals, and everywhere else you see large clusters of rural hospitals. So what's different about a rural hospital that you haven't already heard or already know because you work in one? Well, the financials are very fragile. 25% of rural hospitals operated during 2015 at levels consistent with those that closed between 2010 and 2015. They all suffer from, or experience rather, low service volumes. There are a few options for changing that, at least changing the expense pattern. There are limited capital funds, all of which comes together to give you small volumes in a typically older physical plant where costs of maintaining equipment and infrastructure are relatively high in a margin-strained environment. Aside from the financials, the operations are quite challenging. The staffing is very thin. Multiple people usually wear multiple hats to get things done. There's limited bench strength behind particular areas of expertise. It may exist only in one person. And recruitment into areas with rural hospitals is very difficult given the isolated nature of their location. So the influencing forces that come into play, some of which are internal, some of which are external. Within the hospital, there's a relatively small workforce. They're maintaining an aging physical plant, typically, and the financials are fragile and very limited, if any, philanthropic support. Externally, rural hospitals face the same challenges that urban hospitals face to maintain their accreditation in order to continue to participate in federal programs. And they have their own challenges dealing with the regulatory requirements that vary by state, and as well, we'll be talking about in a moment, new federal standards which are on the brink of becoming implemented later this year, the CMS Emergency Preparedness final rule. The genesis of the CMS rule, if you trace back over the past 15 or so years, comes from responses to healthcare components of recent events, whether it was the anthrax attacks which followed the 9/11 attack by a week, the hurricane known as Katrina, about 12 years ago, swine flu in 2009, that super outbreak of tornadoes during 11 and 12, Hurricane Sandy, and the outbreaks, mostly respiratory, in their effects of MERS, Ebola, and enterovirus. All of these events, whether natural or man-made, expose weaknesses in the response to healthcare emergencies, which in some have become the driving force behind the new federal standards, which are about to become effective. I heard from Lisa earlier today that information will be coming to you by the end of this week or perhaps early next from Everbridge to provide you with a compendium of resources that that Everbridge has compiled from CMS. But in general, the Joint Commission expectations for accreditation and reaccreditation will be adopting, with few exceptions, the CMS rule. At least we won't need to track both. We can only track the CMS and know that the Joint Commission will find that acceptable. One minor change is the number of exercises that CMS expects CMS expects two, but one active, one can be tabletop, versus the Joint Commission, which will still expect 2 annual active drills. Without regard for the number of drills, the number of institutions or provider types or categories is extensive. The CMS rule expects evaluation by 17 different kinds of healthcare institutions, hospital being only one of those. Whether they're inpatient, ambulatory, doesn't matter. They expect high levels of coordination with external agencies. This is consistent with FEMA's whole community concept, and it's a very natural phenomenon to expect in a remote locale or a county with only a rural hospital, because the organic nature of it has people cooperating with each other, no matter their mission, no matter their product or service, in an event that destabilizes that community. Excuse me. The preparedness guidelines focus on risk management, policies and procedures, communication plans, and training and testing. You'll be hearing more about that. So a couple of Nantucket-based examples, some of which may sound familiar. I suspect this one may or may not, but one of the most significant events in Nantucket Cottage Hospital's recent past was the day we lost our kitchen. We knew where it was, we just couldn't use it. And the point here is to imagine risks coming to jeopardize business continuity. They may come from very unexpected sources. We had a previously unforeseen problem with our main drain in the kitchen. It became blocked. We were quickly able to develop a relationship with the assisted living facility on the island, which resulted in our ability to pick up, transport, and eventually reheat meals that were prepared off-site. We had to do temperature checks on both ends, first to make sure that the food was cooked properly and that it would be served warm. We declared the food MOA, which is microwave on arrival, to make sure that it was suitably at suitable temperature before it was being served. But clearly, the food service manager lost lots of sleep over the risks she was facing, not being on site where the food was prepared and cooked. She was worried about allergies, information that we had in-house we had to forward over to the cooking site. She was concerned about bones in fish that was served. She wasn't responsible for any of the preparation and cooking, just responsible for making sure that nothing bad happened. So that left her with some sleepless nights. But the key here is a standby agreement. And this is something that I'll talk a little bit more about later, but if there's a critical service that your institution is facing, make sure you have considered a standby agreement with an alternative supplier to make sure that in such a situation, you're not caught flat-footed about what your options are. Excuse me. The second one I want to spend a minute on was Hurricane Bob, which hit practically the entire eastern seaboard in 1991. This is not a good resolution, but if you look at that shot, Florida is sort of at the lower left. The eye of the hurricane is probably due east of New Jersey at that point, with Nantucket being straight up ahead north and off to the right a bit. A significant storm, not uncommon on the eastern seaboard during the month of August, where we're right in the middle of the most intense period of each year's hurricane season. The difference here, which is why I chose it to contrast with our kitchen, is that this one had predictable timing. We knew the time of year. And it had a multi-day forecast of the track. So we had a sense along the way and in advance of it being a direct threat to us, what we might be facing. The hurricane eventually veered to the west, sort of came ashore in Rhode Island, but nonetheless, southward facing beaches lost about 50 feet of sand. When it hit, the sustained winds were between 75 and 100 miles an hour. The hospital weathered the storm well, although in the days leading up to it, there were daily adjustments to critical inventory levels. And this is about a sustainability assessment, which is how much run rate do we have given the inventory rate for each of the critical resources that we need. It's much like the range indicator on the dashboard of your car. Once you add gas or drive, you're always left with a sense of how much range you continue to have left. And that's what the sustainability assessment should be thought of as a way to give you an advance indication of how much more running time you may have in an institution. One of the more important facts about rural hospitals is the significance of healthcare coalitions. Healthcare coalitions are nothing more than consolidated thinking about regional needs and how different players and entities can collaborate effectively to help the entire population of an affected region. The collaboration with external agencies and resources, whether they're clinical or non-clinical, the typical fire, police, public health agencies are all important, and we'll talk more about that in planning later on today. But there are established regional consortiums in every part of the country. CMS does a nice job in publicizing those on its website. One of the difficulties in a rural hospital is getting the information to people from reputable sources, which is why collaborating on training is an effective solution. Grants for training and response, however, are typically based on population levels, and I call it the tyranny of population-based disbursements because rural hospitals with their low levels of population don't score as high, if you will, as urban areas or even larger suburban areas. One of the common factors or criteria describing critical access hospitals is each one of them has to have a referral agreement requirement in place with an acute care hospital. In other words, a place previously agreed upon for the transfer of patients with needs that exceed those available in the rural hospital. These are all partnerships. These are all, some of which are highly documented, some of which are handshake within the community, but all of them need to be documented because that's what you're going to rely upon when the time comes. It's also important to keep in mind what a rural hospital has for a community and what does the community expect from the hospital. Every community has an emergency management plan because it resides within a county in the country. These have to be, not often, collaborative programs that are developed in concert with institutions in the region. And another thing to consider is a potential surge from another institution. If another clinical entity in the catchment area of the rural hospital suffers damage, maybe its roof comes off in a hurricane, or maybe it has become suddenly without power, you need to anticipate in the rural hospital an incoming surge of patients. This is not about casualties as much as about displaced patients. If it is about casualties, every institution has to understand what its casualty carrying capacity is. This is the concept of knowing when it is that you should stop the inflow of patients, because to continue beyond the capacity of your institution to serve them, you'll merely be relocating the disaster inside the walls of the hospital. Operational continuity for rural hospitals has several assumptions to begin with. The first is you must do a great job assessing the preparedness for both types of events. You'll all recognize the value of a hazard vulnerability assessment, which is at the core of this plan, and how it gauges the probability of an event with the likely severity were it to occur, or in most cases when it will occur. It's important to anticipate the effects of physical damage that's a potential, the potential for disrupting existing services, or in significant cases, due to mostly structural issues, how a specific service may need to be discontinued, not just disrupted. Simulating likely events usually follows the assessment of risks. There are two types of simulations. There are those which are categorized as discussion-based initiatives. They are intended to familiarize the audience with a simulation, whether it's a workshop, which could be for a specific policy, a seminar to orient staff to a new plan, a tabletop exercise usually attended by key personnel to pressure test or assess the effectiveness of a plan. And rarely, but an important option here is what are called games to both test and refine, usually with some competition from two teams, an actual or assumed real-life situation. As you develop plans and go on to develop simulations, it's important throughout to consider every practical risk the institution faces and guard against the strangely foreign risks that you can imagine occurring. It's best to keep the risks that you are evaluating, whether it's through a formal annex to your plan or those that you're considering in general, to consider those that are most likely to occur. Each should be mutually independent of the other, but comprehensively they should be exhaustive of what you imagine your hazard vulnerabilities include. The other type of operations-based exercises, the drills, the functional drill, the full-scale drill, are intended to validate, clarify, and identify gaps in a plan. For a drill, the best example could be a hospital conducting a decontamination drill. It's fairly focused, it's one particular activity. For a functional drill, it could be how the hospital participates with a larger scale emergency operations center. And for a full-scale drill, it could involve public safety and the hospital in the field. In Nantucket, about 2 months from now, we'll be simulating a commuter airplane crash at our airport, which will involve, obviously, responding resources from the airport as well. The town, fire, and police and the hospital will have a go team to go on site and put the institution on alert for incoming casualties. So those are the various types of ways to rehearse, if you will, what it is that your plan suggests should be anticipated. Excuse me. The operational continuity, again, needs to consider, as we've said, customer-supplier relationships, mostly external, but in some cases internal. It would be prudent among the departments in your hospital to consider what each needs from another in the hospital. These are intramural requirements and capabilities. What is it that the emergency department would need from the laboratory? What is it that the medical surgical floor would need from the emergency room, whether it's information or resources, in order to execute its particular mission within the institution? Maybe losing my voice, sorry. Externally, with community-based partners, where might you go for linens if you need them? Are there large hotels that you might have a standby agreement with? Where would you go for food, as we talked about, if your kitchen suddenly was unavailable? Where would you go if the pharmacy you rely upon within your institution depleted its supply of key medications? Where are the retail pharmacies around you? While the packaging might not be great, the drug is the drug. Response planning is grounded in a science known as the Hospital Incident Command System, which has the benefit of being universally understood by multiple agencies that might be responding alongside you. Whether it's the incident commander and the line responsibilities for operations, planning, logistics, finance and administration, or those staff roles for the incident commander of public information, liaison with supporting agencies, and the safety officer. But key questions which should already be in your emergency operations plan is who will lead the emergency, who will hold staff positions, who are their alternates, and identify responsibilities for each of those, not only in terms that are understood by others through the incident command system, but within your own facility, based on the specialized language that you may use, to describe those core functions. Considering evacuation should be anticipated. What would the rules be which would dictate the need to, or the advisability of evacuating? They could include conditions such as an unsafe partial environment of care where you have to essentially temporarily decommission part of your hospital. It could be a catastrophic structural failure of the entire physical plant. You lose the roof to a one-story building. It might be the sequential failures of primary and secondary utility systems. Your electrical feed has been disrupted, the emergency generator won't start. How much time do you have before the batteries in key systems run dry? Are there predictive criteria that can signal the impending problem that should be monitored routinely? Who orders it? That should be a part of your emergency operations plan. Again, identifying backup, if it is typically the CEO, who's responsible when the CEO is not present, and down the line with each of those core positions. What would the pre-decision phase look like? Again, which systems and capabilities warrant monitoring to give you an advance heads up, if you will, about the potential need to evacuate? And most importantly, how will you be triaging critical ill patients? I suspect everyone on the phone has read 5 Days of Memorial. If you haven't, I would recommend it. It's a particularly poignant review of the ethical tensions faced by caregivers in New Orleans during Katrina, and the decisions they had to consider and eventually make when caring for the most critically ill patients in that facility. There's a very helpful guide I found developed jointly by the Massachusetts Department of Public Health along with expertise from Harvard University School of Public Health about some of the guiding principles which should be considered when anticipating evacuation. Clearly, the first and more important response would be shelter in place, whether partial or full. But you do need some pre-event decision guide to help you determine at what point should we be re-evacuating, at what point should we decide that the need to evacuate is imminent and we need to launch a more elaborate plan for assistance. Again, the primary concern is for safety. You need to acknowledge that routine care, as best we know it, will not be optimal in such a case. Full evacuation should be the last resort. Keep it simple, keep it flexible so you can respond to a specific incident. You don't need an evacuation plan for each of your vulnerabilities. There should be department level plans. There should be a designated unit-specific assembly point for patients. And try to maintain like staff, like patients together, rather than distributing them in any other way, to make sure the continuity of care has its best chances. The most difficult decisions here are the ones that emergency room physicians face in triage, which is doing the greatest good for the greatest number, and that's a key part of any evacuation plan. Probably the most important element of any operational continuity plan is communications. Clearly, the constituents here are both internal, the facility staff, making clear what the management's expectations for continued operation are, but externally as well. Multiple constituents here. Patients' families, especially as evacuation is considered. The largest served community, the hospital's catchment area. At what point do you need to inform local first responders or EMS services about disruptions your institution may be facing, which would argue against the arrival of new patients? Related facilities, where will you be transferring patients and redirecting new patients? And the regulators always want to know your current status and how long you might be in a period less than that which they understand you to be routinely providing. The community that FEMA calls whole community is one that's very common in a rural hospital setting and low population densities. You can expect collaboration in those locales given the reality of an isolated community and how people rely on each other much more rapidly, much more instinctively. It's muscle memory. When there's something going on in a community, people band together. In smaller communities, much more, much more naturally and much more quickly than you do in an urban community. So some takeaway suggestions. I tried to get them to rhyme. Anticipate, simulate, and communicate. Figure out what your general risks are based on your location and your facility type and the particular characteristics of your facility, especially if it's aging or you've had difficulty maintaining routine preventive maintenance on its components. What are your particular risks? Don't get distracted by a rare event. Focus on the things in your hazard vulnerability assessment that are in that top right category or quadrant of high probability, high severity. Simulate. What are the ifs? This is no time for an exquisitely developed siloed plan. You're going to be working with others in your community, especially if it's an event that is beyond the hospital's wall and affects the entire community. And remember, one of my favorite sayings, perfect is the enemy of good. You need a good plan. I don't know of anything that's a perfect plan for such an event. And can't stress it enough, communicate internally often and in detail with your staff. They will be able to act appropriately if they understand what the situation is. And externally, both with constituents you serve and collaborators that you'll be relying upon. And that is the end of my remarks. So hopefully there are some questions.
Jack, thank you so much. I can feel the applause coming through the webinar line. That was a fantastic webinar. Thank you so much for presenting that information. I think there's a lot of nuggets in there that people can chew on. I would definitely recommend people to start putting their questions in now. We already have a few in, but we're happy to have some more. If you guys don't mind, I'm actually going to ask you a question, and I'm hoping that you can put the answer into the question box. So the question that I have for you guys is, what is the weakest point of your hospital emergency planning system? So right now, what is that thing that you're the most worried about? I would really like to see your replies, and that will kind of help inform the question and answer period as well. So while you guys are coming together for the questions, yes, we did record the video,
And we will be sending out a copy of the slides, a link to the video on our YouTube channel, as well as other resources. Jack had mentioned specifically that there's 17 different types of hospitals under the new CMS guidelines. The program that Jack is at Boston University for Healthcare Emergency Management, they put together a fantastic sheet for us that goes over specifically what you need to meet by type of hospital. So we'll be sending that along to you with a bunch of other stuff. One of the things that you really need to think about is what happens when a crisis occurs. You need to think about your staff and where are they and how do you get a hold of them. You need to think about resources and supplies, everything from something simple like keeping the hospital rooms clean to medical supplies, pharmaceuticals, things like that. So you need to have a reporting system in place. You need to see who's talking to you, who's responding, who's available, inside the hospital, outside the hospital, and then the CMS guidelines require you now to have that report in place. You also need to think about all of those outside resources that you have, from the Healthcare Coalition to the fire to possibly even pilots at the local airport to help you evacuate if that's what happens. That last picture in the bottom right, I put that there on purpose. When something spectacular like an active shooter or an epidemic, an Ebola patient walks into your emergency room, you're going to have to deal with the press. So I want that to be something that people are thinking about while they're putting together their emergency plans. You know, what are you going to do if the media shows up? How are you going to handle that? So how can Everbridge help you? Well, we can help you run your command center. This particular photo is from Seton Medical Center, and they were running an active drill on patient surge. We are mobile. So we had probably the worst case scenario was an emergency planner was on vacation and executed an entire incident from his phone in a canoe. So we can be there no matter what. We definitely help with that local community aspect, which is so important for the CMS Emergency Preparedness Guidelines. And then beyond that, also the residents in your community and how you're going to serve and protect them. And it could be a language barrier, it could be social mores of a particular community and how you address them. One of the examples I can give is during Hurricane Matthew last year. One of the things that they needed to address was Spanish-speaking residents as well as English-speaking residents. That was something they needed to talk about. I do want to let everyone know that we have a resource library at everbridge.com. It is CMS Emergency Preparedness. We will put that in the email as well. We have white papers on the CMS final rule as well as the interpretive guidelines that just came out. Soup to nuts, we have a lot of information there for you. And we also wanted to let people know about Everbridge General Hospital. It is our test facility. It is a live facility where you can see responses. And we are happy to have you in there. You can see how our templates work and how everything executes from reporting to managing an incident. Okay, from here, if you have any questions after the webinar and you'd like to reach out specifically, my email there is right at the bottom, and I will coordinate with Jack to get answers for you. It's lisa.johnson@everbridge.com. If you would like to talk to somebody right away, that phone number is also good. People answer it during business hours, so feel free to call then. Okay, and we are going to go to our first question, and it's one that we get very often, which is, how do I convince hospital management that they need to be involved in emergency planning?
I would guess that hospital management includes people, hopefully some with clinical training, who can appreciate the need for preparedness. That's often more likely to be the case than it would be if someone in management who didn't have any clinical background, because you never know what's coming through the door, you never know what's coming at you from the sky, you never know what's coming at you from, frankly, any direction. The trouble with getting attention is, unfortunately, the competing demands that that same team is facing. And when devoting resources to what might be a rarely occurring event or what might be an event which never occurs is difficult, given the exigencies of the regular day and all the trials that the hospital administration faces each and every day that are real, that are in front of them, that are not imagined to be happening perhaps 6 months from now or perhaps never. It's key to make sure that that hazard vulnerability assessment is developed with hospital management, so you're all working off the same Ouija board, if you will, about what could occur. It's difficult when that information is developed or that exercise is undertaken in a vacuum by someone accountable for emergency planning without bringing along hospital management, bringing them along the way. I think that's the best answer I can offer.
Okay, great. And then I want to thank everybody for putting in what their weakest link is, because a lot of you have the exact same one. I would say about 70% of you. The comment was that they don't have the staff in place to handle an emergency. So I'm actually going to draw a question out of that, which is, how do you get more staff? So is there a way that you can get more people inside the hospital facility, or is there a way, should you be looking outside into the community, maybe for volunteers? Do you have a comment about that?
All I would say is that in an emergency, everyone is part of the response. There's not a group of people who will descend from the sky to help you manage your emergency. On a large scale, that's FEMA's whole community response. On a small scale, there's no cadre of resources that will appear on your doorstep when your power goes out, or when your kitchen is gone, or when you have a sudden surge of patients. You will be on your own. FEMA suggests that you will be on your own for some time. Don't wait for them, is the translation of everything I've read from FEMA. But even the Joint Commission now has a 96-hour rule, and I think that's part of the CMS rule as well, which is you should expect to be on your own for 96 hours. So by extension, how do I get more staff in an emergency? It's the staff that you have. Their duties will be altered. They may find themselves doing things they've never done before, but you have to prepare for that, because the help will not be arriving as fast as you would want it.
Excellent answer, thank you. And then a question from Lance. Given the possibility of supply chain issues, do you recommend the use of stockpiles? If so, are there recommendations for what operating period such a stockpile should be built for? So we had just talked about 96 hours. I don't know if a rural hospital would want to consider, possibly more. Like if you are connected by a bridge and your bridge washes out, is 96 hours enough?
Sure. Well, on an island, 30 miles at sea, which is my experience, that food service manager that I described in the reciting the details about the kitchen going offline, now maintains a 10-day supply of food, which is non-perishable or frozen, which relies on electricity, obviously. But I don't know if that was her, frankly, I don't know if that was her inventory level before the event. It certainly is her inventory level now, and she's prepared to feed 80 people for 10 days. I know that that was in direct response to the event. I doubt it was something that she maintained even before we lost our kitchen. Stockpiles are important. Clearly, things that have no expiration date, medications, or other date-sensitive items can be stockpiled. I know in hurricanes, typically Walmart is the place people look to. Home Depot is the place people look to for a stockpile, if you will. Those can become quickly depleted while your responsibility to manage your hospital doesn't go away. Those stockpiles may. So I think it would be prudent to have stockpiles of especially those things that are critical to maintaining operation, and those come from your hazard vulnerabilities. What is it that you would need to have in place, specifically by category? How much of that is difficult to say. I think 96 hours is an absolute minimum. If finances can support it, I would go longer than that, but do so in a realistic way. You're not going to develop the national cheese stockpile, which I think exists somewhere beneath ground, in response to a potential disaster, but you do need to be conscious of the resources that you need. And to the extent those are not date sensitive, to have a reasonable supply on hand. I know it's a vague answer, but if you're 30 miles at sea, the answer is going to be different than if you're 30 miles down the road on an interstate that is unaffected by a disaster.
Yeah, and I mean, it's always the case that you need to look at your natural environment and what obstacles and positives you have. I know just Burlington, Vermont, which is a city, but they have major problems with internet connectivity and wireless and that sort of thing. So they need to think outside the box. It's not necessarily the best option to send a text message to everybody because you might not get it. So that is, every region is going to have different options. So our last question for today is any mitigation ideas for dealing with staff family in an emergency department, such as daycare, or I'm going to add on to this question because it was a big deal for Hurricane Katrina, pets. So how would a hospital address, I can't come in because my dog's at home?
So I'll go back to Hurricane Bob and other hurricanes, that one of the things that the town of Nantucket did in developing its response for opening the Emergency Operations Center is for people who were staffing key positions. Once there was an initial briefing to those individuals about the impending scenario, the first thing that the Emergency Operations Coordinator did was, now go home and take care of your family. Make plans for you not being there for the next 3 or 4 days. In other words, deal with your family first. I do know on occasion that there have been family members brought to the hospital. We did not bring any pets in, although we do have a pet program for patients. We do not have any plans to accommodate families' pets, but that is certainly the case for children. And I think it comes down to not relying on the hospital per se, but relying upon other resources in the community to take care of family members, including pets. So I don't have any smart answers on this one, other than to anticipate that as a staff person critical to the delivery of care, you should anticipate, if it's an event which has some lead time to it, not being home for several days, and all that means. In an extreme situation where you are perhaps a single parent with a young child at home, there's an already in place some sort of care coverage situation for when you are working that has to be expanded, or at least considered for expansion during this time period. Beyond that, it's really a difficult question to answer, I think.
Yeah, and I would just add, one of the points that was brought up to me when we were putting together this webinar is that rural communities are incredibly resourceful and incredibly interdependent. In a city, you might not know the neighbor on your floor, but in a rural area, you probably know a good chunk of the community. So hopefully there's always people around that can step up.
Lisa raises a good point, because while it may be something that emergency department staff feel, it's probably no different in a situation that affects an entire community, that the same situation is being considered by other people. So it's not limited to the hospital, although it would be if it were a surge that required beefing up staffing in the emergency room.
All right, and with that, we are going to wrap up. Thank you so much, everyone, for attending today. We hope you have some useful information that you can apply immediately at your facilities, and we will announce the next series of webinars soon. The next one for sure is on August 3rd, and it is about using social media during an emergency event and how you can use it for the positive for your hospital. Again, we will talk soon. Thank you for coming today, and have a good one.